What is ME/CFS? First of all, it's an illness that's triggered usually by a viral infection. Flu, glandular fever, chickenpox, almost anything can be a trigger. And there is also genetic vulnerability, which means that people who get this illness may well have family members who've had it. It doesn't always follow. I mean, most of the people I've seen over time will say, no, they've never heard of anybody in their family with it. But there is, proven to be a slight genetic vulnerability. And what happens when you get a virus infection, your immune system fires into action to kill the bugs. That happens, assuming you've got a normal immune system. And then the immune system in this illness just doesn't settle down properly. And when your immune system's activated, you feel very, very tired, and you get a lot of symptoms, as will become obvious as we're talking. The whole chemistry of the body seems to get quite upset, and there's imbalance of various aspects of the body functioning. And the symptoms that are ongoing through this so-called post-viral phase, or whatever you like to call it, are often very similar to the initial illness. So if your initial illness was maybe, let's say, meningitis, which involves inflammation of the brain, a lot of the ongoing symptoms will be very similar. Epidemiology means a bit of statistics, the boring stuff in a way. How and when is it occurring? It occurs throughout the world. Even in darkest Africa, there have been research studies done on people with this illness. The initial illness affects a large number of the population. I mean, hardly anyone around who hasn't had a viral illness, but how many go on and get chronic fatigue syndrome? And they think probably up to about 1% of people who get a viral illness may well end up with CFS. And this is going to become much more apparent and talked about since we now have what we call long COVID, which is the same illness but following on specifically from COVID. So you do get a change in the incidence probably over time, because initially we were thinking, about up to 20,000 New Zealanders with this illness. Now with long COVID, that figure could even eventually be doubled. It's a bit of an unknown. People can be very severe with this. They wouldn't be here today. They're totally bedridden and housebound. But all age groups are affected. I've seen young kids of 4 and 5 who've had this illness diagnosed, right through to very, very elderly people. But at the common extremes like that, the extremes of youth and old age, it's very hard to actually make a diagnosis, because a 4 or 5-year-old can't really tell you much about how they feel. They don't know any different. So it's very hard to diagnose in young children, and very hard to diagnose in very elderly people, because they've often got a combination of other things going on. So, kind of making a diagnosis is quite hard. What do we call predisposing factors? Things that lead into this or make you a bit more prone to it. Certainly there's the genetic side of it. You may well have a bit of an inherited tendency. And then mental and physical distress. So extreme over-exercise. Athletes will often not be able emotionally to give in to illness, so they keep trying to train and they over-exercise. Certainly there will be exposure sometimes to toxins or accidents, surgery, immunizations. All these things might play a role in how one does develop the thing. And also sleep deficits. So if a person is lacking sleep because of maybe a young baby or shift work or just a poor sleep kind of pattern, they're much more prone to go on and get this illness because their natural recovery from sleep, which we should all be experiencing, is just not occurring. But the most likely trigger is always going to be a virus infection, combined probably with some of those things. And which viral illness? Well, it could be any, as I said just now, and we now have long COVID coming into the picture. They're calling it long COVID because that's really what it is. It's COVID infection, a viral illness, and then it just drags on and on and on. We may well find that people from long COVID actually do recover better than people with the traditional type of ME illness. On the other hand, they may take longer. And in all these instances, there will be some people who never seem to recover. And they have the illness very long term, sometimes 20, 30 years or more, which is very sad, really. So if you can see that, this is the typical story we see following a viral, with and following a viral illness. You get that initial peak of violent immune activity in the first few days of the viral illness when you feel at your worst. And over about a month, 90% of people who get, let's say, flu or glandular fever, they will have recovered. So at 1 month, most people will have fully recovered from a viral illness. Another 6 months, there will be people who are very, very slow to recover for various reasons. And we call this the post-viral phase, or this is often described as post-viral syndrome. And the symptoms come and go a bit, and that's the wavy line, but gradually the person at 6 months will have recovered nicely. But there will be that 1% who go on and don't recover for a very long time, and some not at all. And again, it'll be in a bit of a wavy line type of recovery phase. I've already mentioned athletes are very prone to getting this, or highly achieving busy people. You know, they don't stay off work. They don't go to bed and put their head down and rest, which is probably what we should all do when we get a nasty bug. So what are the main symptoms? Well, I've already mentioned some of them. There will be certainly fatigue, a lot of flu-like symptoms, sometimes tummy upsets, headaches, fibromyalgia, which is muscle pain, and sleep disturbance, and so on. So the symptoms are many and varied, but often very much the same as what the initial illness might have been for that individual. There's been a heck of a lot of research going on. I got involved in this illness probably about 40 years ago, but its description goes back to ancient Greece. A philosopher called Hammurabi first described the illness in any sort of literature, and we're talking real ancient Greece stuff. And this has been described over the many, many hundreds of years since then, and various people have been shown to have suffered from the disease, such as Charles Darwin and Florence Nightingale. But the research has been going on for many, many years, way back to the early part of the last century. There were descriptions and research going on where there were outbreaks in various places around the world. There was an outbreak of a very nasty bug in Iceland, and Iceland's a very small population country, so it's kind of easy to follow up things in a small population country rather than, say, the United States or somewhere like that, where we're talking thousands of people spread all over a vast country. So they followed up in Iceland, and again, it was known then as Icelandic disease. This was in about the 1930s, and even to this day, there are still people with this illness who haven't recovered from that initial Iceland outbreak. So there's been a lot of research and lots of work going on over the years by various top researchers in countries all around the world. I won't go into this list in detail, but it's just to show people that there's a huge amount of research going on covering and looking at various parts of the body and the various systems of the body to try and find out exactly what might be going on in this illness. There's particular interest in what we call metabolomics, which some of you may understand what that means. Some may not have ever heard the word before, but the metabolome is like the way your body chemistry system works. And they've found that there's been a lot of abnormalities in these systems. One of the big frustrations with the illness has been that they haven't really understood exactly what's going on specifically to be able to come up with a lab test that makes a nice firm diagnosis so you can say to a person, yes, you've got this illness. One of the frustrations for people with this illness is that nobody's really been able to kind of say definitely, yes, this is it. But the metabolomics has shown some very real abnormalities in the body chemistry, particularly described by this man called Navio. And it's likened to a bit of a hibernation type of state that animals, bears and things go crawling underground in the winter and hibernate. And what is shown is that some of the chemistry that's abnormal in chronic fatigue syndrome is very like the hibernation state, which may well be a follow-on type of research which will be shown to be very, very important. Biomarkers are ways that we make a diagnosis. So if a person, for example, has diabetes, high sugar levels are part of the way we make the diagnosis. That's a biomarker, the high sugar level in diabetes. But in this illness, as yet, although there's this great big long list which goes on and on, there's no one specific test that has been shown to be particularly definite for this illness. A lot of abnormalities are found when we do all sorts of lab and scans and what have you testing, but the abnormalities are not absolutely specific to be able to say, yes, this must therefore be chronic fatigue syndrome. It might be, and it might be this, and it might be that, and so on. So having a kind of definite blood test will be a wonderful breakthrough if and when it comes, because one of the difficult things for people with this illness is nobody can say, yes, you've definitely got it. And that leads to all sorts of problems, both emotionally and socially and what have you. Again, I won't even begin to go into what's written here, but just to show you one of the leading researchers, this guy called Don Staines and his co-worker Sonia Marshall-Grodiznik, they work in the Gold Coast, and they're very, very close to coming up with a laboratory test that may prove that the person has actually got this illness. It's called a TRPM3 receptor abnormality. Meant very little to me a couple of years ago, but I've sort of learned, and life is like that for medical people. We go on learning almost day by day, and this has been shown to be quite a serious abnormality in the way that calcium moves in and out of the cells in your body, and this may well lead to a laboratory test. And similarly, we have Warren Tate. He's a professor of biochemistry down in Otago, a very well-known person internationally. He was awarded the Rutherford Medal, which is New Zealand's highest scientific award. And Warren is, again, very interested in this illness and is devoting much of what should be his retirement, because he's certainly getting on in years now, but he's devoting a heck of a lot of time to chronic fatigue syndrome, and again is finding abnormalities that seem to be quite specific. And I must underline the word seem, because people get very frustrated when there's not a lab test that works, absolutely, but you've got to prove that the abnormalities you're seeing are only specific to this one illness, not to all the thousands and thousands of other illnesses that might be out there with very similar sets of symptoms. And just recently, a new piece of research has shown 91% reliability of an abnormality, but 91% actually is not enough. It may sound good, but it means, nearly 10% of people are still floundering around, not quite sure if they've got it, and it's too soon to be able to release this sort of test, and certainly everyday laboratories wouldn't be able to perform these tests. Some of the machinery to do some of these research tests, and this occurs not just in this illness but in many illnesses, but some of the machinery costs millions of dollars. So, your lab down the road isn't going to be able to sort of, kind of say, yes, come and drop your blood off, we'll do it for you. It won't happen. It could be a long, long time. Warren Tate from Otago says, and I'm sure this is a very apt kind of quote, that this illness is a bit like a molecular jigsaw which is fitting together slowly, but we've still got some gaps in the jigsaw. We're still not quite there. So how do we make a diagnosis? Well, this is kind of the way we make a diagnosis in many illnesses, because there are many illnesses like this that don't have a lab test or a specific thing that we can pinpoint. And so we have to go through what we're taught in medical school, a whole series of processes to get to a diagnosis. So this applies to every illness, really. So we take a careful history from the patient, we listen, find out what the story is, and then need to examine the patient, obviously, to try and see if we can eliminate certain things or focus on certain abnormalities that we may find on examination. Do a routine blood screen, which go down to your local lab with the lab form, and that's relatively easy to organise. But this is specifically to eliminate other illnesses that might creep into the picture or have crept in. And there may be other investigations that are important. For example, if a person's got a lot of chest pain associated with the illness, we might do an ECG, which is a cardiogram of the heart. We wouldn't normally do that on every patient, but it's, again, we pick out the things that are most important. And also, it's very important always to review your patient psychologically, because a lot of psychological illnesses are accompanied by a lot of physical symptoms. And of course, the more we worry about a physical symptom, as we all know, the worse it gets. If you get a pain and you don't know what it's caused by and you worry about it, the pain will get worse. So we're looking at a process of elimination. And then we say, does the person fit the diagnostic criteria for this illness? And various criteria have been brought up by these different people on that slide there, ways of making a diagnosis according to a process of elimination. There are, of course, a lot of other overlapping conditions that we have to either eliminate or say, yes, actually this person has got such and such, they haven't got chronic fatigue syndrome. And we're looking at things particularly like undiagnosed cancers, hormonal imbalances, particularly in women, POTS you may never have heard of, but it's a tendency to have very low blood pressure, and when you stand up your blood falls into your feet a bit and your blood pressure gets lower, so you feel very faint and dizzy. Postural orthostatic tachycardia syndrome is what POTS stand for, but that's a bit of a mouthful. So lots of things have to be eliminated. We have to make sure that these things are not the cause of the illness, or they may be overlapping with the illness. So the person may well have chronic fatigue syndrome, but they may be suffering from a neurological condition as well, or they may be very obese, and that is extremely tiring, and so on. So we look at all these possibilities, and these are again another few overlapping conditions that people often have in association, particularly with chronic fatigue syndrome. Chronic fatigue syndrome upsets the whole body chemistry and blood system, so some of these other conditions will show themselves or start to occur as well. So, you can have more than one thing wrong with you. So how do we get on with dealing with the illness? What do we do to help people get through the illness? And the first and most important thing, of course, is to have a correct diagnosis. It's really, really important that in medicine, in every branch of medicine, because if you're treating the wrong thing, you may be even aggravating the real thing. So you've got to be very careful that you get the diagnosis correct and go on looking at the diagnosis, not just say, right, this person's got chronic fatigue syndrome, we forget about everything else, because they may have more than one thing wrong, or we may have got the diagnosis incorrect. So having made a good diagnosis, what do we do about it? Well, certainly in every illness there needs to be a certain amount of stress management, and just giving a person a diagnosis relieves them sometimes of a lot of stress. They've been worried for a very long time. On the other hand, it can create stress because they are suddenly, faced with the reality of a nasty illness. Will they be able to go back to work or school or what have you? So looking at the stress in people's lives is an ongoing issue in medicine, particularly in general practice, where you get to know your patient and know the family and the background and do everything you can to help them get on with life and resolve the stress. Also very important that people with an illness like this who are confined sometimes to bed, or certainly not able to get outside much because they're ill, getting outside is really, really important, because we know for sure that vitamin D is released or manufactured in your system with sunshine on your skin, and you release melatonin, which is a sleep hormone, in response to exposure to daylight. So time outside is a simple thing to be able to recommend, even though it can be very hard, and some people can barely get out of the bed and outside into a chair, but we have to encourage that because it's part of the management program. A little bit of exercise is important, in that if people lay around in bed all the time, they get very much weaker and they lose muscle bulk, muscle tone and what have you. But when we're talking exercise, we're not talking going to a gym or getting involved in extremes of exercise. We're talking of stretching, maybe even for some people just doing things like that with the hand, or waggling their toes, or bringing their knees up and down, or sitting on the side of the bed and standing up. These are people who are very ill, but then people who have the illness who are, let's say, still able to go to work or school and lead a moderately normal life, they still need to do a little bit of exercise, but we know for sure that too much exercise leads to aggravation of the illness, what we call post-exertional malaise. So it's very hard sometimes for a person to work out what will be right for them. And we have to make sure that we if anything, hold back on the exercise recommendations, because too much exercise can very easily lead to a worsening of symptoms or even quite a serious relapse. And there are guidelines from the UK particularly, which advises this very cautious approach to pacing. The diet needs to be adequate, and nutritious. Again, when people are confined to home, they often can't get out to shop or they can't get up to cook, and they become very narrow in their diet through no fault of their own. They just haven't got the energy to do it or anyone to help them. So encouraging a reasonably nutritious diet, an adequate diet, and eating little and often. Again, overeating too much in one hit is a bit like over-exercising. It can really aggravate the symptoms. So a kind of 2 to 3 hourly approach to eating, and perhaps nibbling a bit in between. You find that generally people with this have a low blood pressure, and extra salt will raise the blood pressure a little bit and give them an improved sense of well-being. But again, needing to watch the blood pressure a little bit. Some of the symptoms are certainly due to very low blood pressure, the dizziness, feeling faint, getting up suddenly and feeling very woozy, everything on go slow, brain function and what have you. Low blood pressure means very sluggish circulation. So extra salt can help, and a drug called fludrocortisone helps to retain the salt, but the blood pressure needs to be monitored carefully. So supplements generally are not the answer, in that if your diet is very poor, you may well need to supplement it a little bit. But to be very aware of the fact that there are a lot of people out there selling a lot of supplements which are said to cure anything and everything, and very rarely do cure anything and everything. So I think if your diet is poor, yes, do. I mean, if you're a vegan, you might need iron, for example. But in the illness, we find that magnesium can alleviate some of the cramps and pains, particularly at night. Vitamin B12 has been shown to improve brain blood flow and give some benefit to some of the symptoms. Coenzyme Q10 is a sort of muscle chemistry that can improve some of the symptoms, and vitamin D important, particularly if the person doesn't get outside much. Again, I'm not saying these things are an absolute must or even might help at all, but they're worth considering. But sometimes we need to keep an eye on the blood levels to make absolutely sure that we're not getting excesses. Hormones are an important consideration too, and I mean, a lot of the hormones our bodies produce can be checked and should be checked, certainly with the initial evaluation, and then probably every 6, 9, 12 months one should be having a routine blood test to check out things like your thyroid and diabetic hormones and things like that. But particularly in this illness, there is some evidence that women get the illness more commonly than men, and sometimes the female hormones can be supplemented and give some benefit. I'll talk a little bit about that later on. There hasn't been much work done with men and male hormones with this illness because they don't seem to be going out of kilter in the same way as the female hormones do. Who knows why? Treating POTS, that's the lightheadedness, really important, so that if the person feels faint a lot, or if it's like a school kid who has to stand in line outside on the netball court and in the hot weather or something, they can begin to feel very, very faint and lightheaded. And again, these symptoms need to be recognized and treatment offered to try and alleviate them. Sleep management, really important. I'm going to talk a little bit more about sleep in a minute, so I won't now. Because people get a lot of pain, that needs to be treated, but ordinary painkillers often don't do much, and we tend to use a group of drugs called the tricyclics. Tricyclics, amitriptyline and nortriptyline particularly, are used in higher doses to treat depression, but they're very useful in very tiny doses to treat pain. But they have to be taken regularly. It's not like a Panadol you might take because you've got a headache or a sore toe. amitriptyline, for example, needs to be taken regularly, daily, and it will take probably 2 weeks before the full benefit is achieved. So there's a lot of, kind of manipulation needed in the way we treat this illness. I'll talk to you a little bit about what we call LDN, which is at the bottom of that slide there in a minute, because that's a little bit of a different thing. And there are a lot of drugs under trial, but the problem being that people, well, not the problem, a problem being that most people with this illness are very, very sensitive to medication, and they can only tolerate very tiny doses, and it has to be monitored very carefully and built up very slowly. So our management of this illness is a little bit dependent on that approach. Whereas, if you've got other illnesses, you can slam in often with quite high doses and the patient can tolerate the drugs quite readily. In this illness, people are very, very sensitive to medication. So I'm just going to talk a little bit about sleep, because in my way of dealing with patients in the past, I have found that dealing with the sleep is top of the list, really, because sleep is the time when our bodies naturally heal themselves and recover from day-to-day activities and so on. And that's just a typical sleep cycle, and you can see, if you follow the white line, that's what happens to us during sleep. We have 4 or 5 phases of sleep through the night, the phases being the deeper, lower levels, where it's right down at the bottom. So you have 2 phases of very deep sleep, and then as the night progresses, the levels of deep sleep become less deep. But during those deep levels, you produce a lot of the hormones and chemicals that have a healing effect on your body. And what we find in people with chronic fatigue syndrome, often they don't get enough of the deep levels of sleep. They get asleep. You'd think because they're tired they'd sleep all the time, and some people do seem to sleep an awful lot, but when they've been measured they don't get those deep levels. So medication for sleep management is very much focused on the type of medication that will improve the deep level of sleep. So a routine sleeping pill like, say, Zopiclone puts you asleep, but it doesn't necessarily give you those very deep levels that you actually need, because that's during the time when your body recovers and heals itself from daily activity. So the medication we use for sleep, again going back, I mention it because I did before, amitriptyline or nortriptyline will give you, even in very tiny doses, some good deep levels of sleep, which are much more healing and restorative. A lot of sleep studies have been done, and we know for sure, as I've just said, you don't get enough deep level 4 sleep, and your sleep routine may be disrupted through the night because of that. You may be up and down like a yo-yo, you may wake up to go to the loo, think you do, but you don't really need to. Your level of sleep can be quite shallow. A man called Martin Partanen in Finland has been doing some very good research on sleep management and in this illness, and he's particularly focused on one of the underlying mechanisms to our sleep called the orexin system. And orexin is a hormone that you produce or don't produce, and if your levels of orexin are low, you actually feel sleepy, and if your levels of orexin are high, you feel quite lively. And the low orexin level, which is feeling sleepy, is if you have a snack, and particularly a sugary or carbohydrate snack at bedtime, that pushes your orexin levels down and you feel more sleepy. If you go to bed maybe a long time since you've had anything to eat or haven't had a snack or anything, your orexin levels will not be responding in the way we'd like. So it's actually a good idea to have a light snack at bedtime, probably a carbohydrate snack, maybe a some bickies or something like that, and that will give you a better chance at a better sleep. Again, it's early research, but I think he's a very well-known international sleep researcher, so we have to listen to these people. A lot of other drug trials are going on, and I picked out 2 drugs there. I wouldn't begin to go through the whole lot because we'd be here all night, but the pyridostigmine is a drug that's used in neurology to treat an illness called myasthenia gravis, and they have shown that it actually does have some benefit for some people with this chronic fatigue syndrome illness. And low-dose naltrexone is another one, it's a very old-fashioned drug, and it's been around for a long, long time. It is used in general medicine to help people come off addictive drugs like heroin. It sort of counteracts them, and you may think, well, how the heck does that fit in with chronic fatigue syndrome? Well, what they've found is many doses of it do actually, for some people with chronic fatigue syndrome, probably about 60% have some very real benefit. So we're talking a tiny amount, a drop in the ocean really, and it does seem to provide the patient with some relief from some of the symptoms, and in itself it's not addictive or habit forming. It's got a couple of downsides, one being the cost. You do have to pay for it, and I think we're talking $50, $60 a month, something like that. So it's not like mega bucks, but for many people on a benefit, for example, because they're ill, it's an added cost that's difficult, and they can get some government support. For some people, there's no response whatsoever, and again, we're too early in the research to understand why that might be, but it's certainly not unusual to find that some people will say, well, I've tried it for 6 weeks and I've had no benefit, but about a third of the people get a pretty good result from it, and a few people do get side effects. They feel worse. But a very small percentage. But it's one of those drugs that is worth considering, that's for sure. The mechanism is it helps that, you may take your mind back if you're still with me, your movement of calcium in and out of the cells, particularly in the brain, is abnormal or thought to be abnormal in this illness. Some of the research from Queensland is showing that, but this drug seems to alleviate that issue. So it's possibly correcting a very big abnormality in our system, particularly brain cells. There are various ongoing issues. People ask often, is it okay to get pregnant when I've got this illness? What about contraception, hormone replacement? Well, estrogen is the female hormone that does seem to alleviate quite a few of the symptoms in women with chronic fatigue syndrome. I wouldn't say all women, but quite a high percentage of women. So pregnancy actually can be helpful, though you don't stay pregnant for more than 9 months, and then you have a new baby to cope with. So it's a bit of a two-edged sword, but certainly a lot of people I've seen in the past have said pregnancy set them on the right path. Contraception, of course, has estrogen in it, or at least some of it does. Most oral contraceptions are estrogen-based. They can be helpful. And for older women, hormone replacement with a very small dose of estrogen daily can be helpful too. As I said earlier, male hormones have not really been looked into yet, and they're a different style of hormone, and we're not going to feed our men estrogen, else they'll all grow boobs. So, you know, that's not what they would choose. Immunizations are an issue to consider, and it particularly came up when everybody was needing to be immunized against COVID. There will be some patients who are aggravated by immunizations, only a very small percentage. The majority can tolerate them all right, but those that are aggravated by immunization often do have quite severe reactions, and there will be some people whose initial illness seemed to start with an immunisation. So I remember one of the very first patients I ever saw had a smallpox vaccination, and she had a very bad reaction to it, and she didn't ever recover. She ended up with a very severe, nasty illness. So I think if you need an immunisation, you need to weigh it up very carefully, but at the same time bear in mind that the illness you're being immunised against might be even worse. So, you know, again, a bit of a two-edged sword, really. And then we need to be thinking about ongoing surveillance with this illness. People need to remember that they need their regular maintenance, things like cervical smears, breast checks, routine blood checks, prostate checks for men, and so on, because it's tending to be forgotten. When you have one illness, you tend to sort of focus on that and forget all the other things that might possibly, potentially be going on in your system. And also, if you develop new symptoms, you might have had this illness, let's say, for 3 years or 10 years or 6 months or whatever, but however long you've had it for, any new symptoms should be reported, because they may make a difference to the way you're treated. They may make a difference to the diagnosis. It may be you've actually had something else going on all the time, or it may be a new illness that's added in. So you do need to be watching for new symptoms and getting them investigated. And any new treatments that come to light that you've heard about, your doctor may not have heard about them either at that point in time, because we cannot keep abreast of everything that comes out in medicine. It's too big. So sometimes you might need to go to your doctor and say, oh, you know, I've heard about such and such. Would that be helpful? And your doctor may have to go up and look it up. We all do that all the time. Or it may be a totally inappropriate treatment. It may be something that's actually quite toxic or dangerous, and someone has just mentioned it, you know. So you do need to discuss these things with your doctor. Now, I've seen probably over time about 7,000 patients with this illness, and who thought they might have the illness, or whose own GPs thought they might have the illness, but about a third of them we've ended up with either a different diagnosis or an added diagnosis. So they might have had chronic fatigue syndrome, but they might have also had a heart problem as well, and you know, things aggravate each other in that way. It's also important to realise that as you get older, symptoms may get worse, and also you become at risk of other illnesses like cancer and so on. And attached to your chromosomes, which are in every cell in your body, are little spikes called telomeres. And they found that in this illness, chronic fatigue syndrome, the telomeres, which, you know, you can't see or feel or anything like that, but they tend to age more quickly than they should. And that seems to be related to the illness. It doesn't mean to say you're not going to live as long, but you may sort of tire out a bit sooner than your next door neighbour who seems to be going for a run every day. So, you know, these things are important parts of research, important to understand and know. I think, you know, a few important messages as we begin to wind up this session. First of all symptoms are going to be aggravated by stress. That applies to every illness. Over-exercise and overactivity, particularly in this illness. People need to slow down, acknowledge that, and watch what seems to aggravate their health, and pacing themselves very, very carefully, and getting outside as much as you can, even if it's just sitting by an open window. Don't expect the daylight through glass to give you release of vitamin D or build up of vitamin D. It needs to be unfiltered daylight. And practice regular relaxation so that you are doing the best you can for your mental well-being. And we're talking all sorts of techniques. Everyone's got their own favourite. It could be listening to nice music or meditation, mindfulness. Any of these approaches are worth a try. They're not going to cure your illness, but they will certainly help you deal with the stresses that might be aggravating your illness. There's been a lot of talk, and I will mention it, about the so-called lightning process, where people have been drawn into a psychological treatment which is said to almost cure this illness. And I think I would always warn people to research very thoroughly themselves what the claims are. There are a lot of charlatans out there claiming to be able to cure the illness, be it by the lightning process or some new supplement or what have you. A lot of people out there aiming to make money out of vulnerable people. So always question things very, very carefully, and maybe even discuss it with your doctor or therapist or whatever. Having a support group really important, and I know this isn't a specific support group that we've got here, but getting together with other people with this illness and discussing your needs and fears and what have you can be very helpful, but also if you're an isolated person because of an illness, it gets you out there having a little bit of fun and laughter, and I think that's really, really important because so often it can be very, very more depressing really to be stuck at home, not getting together with people and having a laugh. And I always say at the end, all ME patients can experience a better quality of life with compassionate care and a multidisciplinary approach. And you need to feel in control of your health rather than being controlled by a particular illness. Again, these things apply to every illness, but important to sort of remember and note. And there are resources out there. I know you can probably hardly read that, but I can certainly supply Debbie with the copy of these slides so that if anyone wants them, they can have them. And I've written a few books, that's one of them. And again, these are readily available through the ME Association, which that's up there, the ME Association. ANZMES is our local New Zealand one. And they provide lots of literature and information, which I think, can be very, very helpful and useful. So I will stop there.
Thank you so
But
much.
we can have some questions, perhaps.
Absolutely. Does anyone have any questions for Dr. Vallings?
Yeah.
Good information there.
I was wondering, do you know of any links between chronic fatigue and functional seizures?
Sorry?
Do you know of any links between chronic fatigue and functional seizures?
Functional seizures. Okay. This lady asked, do I know any association between chronic fatigue and functional seizures? Functional seizures being a form of epilepsy or even migraine sometimes. And, I don't know that any research has actually shown that functional seizures and ME are related, but ME has certainly a lot of symptoms where people do have almost like epileptic seizures, certainly a higher incidence of migrainous type things, and migraine can lead into seizures too. So a lot of neurological symptoms are associated with chronic fatigue syndrome, but I think if a person has neurological symptoms, they do need to be monitored by a neurologist, or at least seen by a neurologist, and have the requisite sort of scans and things done. Okay. Any other questions at all? Yeah.
Do you have any sort of advice around the brain fog or the memory sort of issues around? Yeah.
Yeah, okay. Well, brain fog is a common term that's used in chronic fatigue syndrome because it describes very accurately a lot of what's going on. And so again, I haven't focused much on it today, but brain fog is whereby people seem to have an awful difficulty in focusing. Their brain tires very readily, and they do feel foggy and unable sometimes to hold a job or concentrate on anything for very long. Even reading a book, you know, becomes a real trial for some people. So certainly brain fog is a common symptom. In fact, it's one of the main reasons why many people with the illness can't hold down a job. And certainly, you know, as long as it's been investigated properly and the blood pressure has been checked and monitored, extra salt can improve brain blood flow. It's not an absolute and it's not a drug or anything, but increasing the salt intake in one's diet can improve brain blood flow a bit, but it's helping to alleviate a major symptom. It's not fixing it, let's put it that way. So I don't know if that answers your question really. Yeah.
Does brain fog affect your blood pressure? I heard you saying something about that.
Does brain fog affect your blood pressure, is what you're saying? Well, not really. It's the other way round in a way. The brain fog may be due to poor brain circulation. That may be one reason, which may be due to low blood pressure. So the brain fog is often associated with low blood pressure, or the brain fog may be due to a certain amount of inflammation of the brain cells. They have shown that the brain cells in this illness can be quite inflamed and therefore not functioning efficiently. Again, that's nothing to do necessarily with blood pressure, either high or low. It's just one of the kind of effects of the illness, really. But brain fog is a very, very common symptom. I think the two commonest symptoms, really, that you see in almost every patient with this illness will be brain fog and what we call post-exertional malaise, which is extreme aggravation of symptoms due to overexercise. Well, overwork, yes, yeah. Just overdoing it, you know. I mean, for some people, overdoing it is to get off the bed and go to the loo, you know, and they kind of, by the time they get back to the bed, they're absolutely had it. And those people are not going to be here today, obviously. But that so-called exertion, which, you know, going to the loo is not really anything other than a normal exertion, can really knock some people sideways for, you know, might take them an hour or two to recover. And I mean, that might seem hard to understand, but it's the reality of this illness. Yeah.
I've got two questions. So the first one is, what's the pathway like to getting diagnosed? So you go to your GP,
Yeah.
and then they run all those tests. But
Yeah.
they send you to somebody like what you used to
Okay.
do?
So this lady's asked, what's the pathway to getting diagnosed? And that's a difficult pathway, actually. But yes, your GP should always be your first port of call. Your GP should be gradually getting more information and knowledge about this illness. It's certainly being taught in some of the medical schools quite thoroughly now, particularly Otago. So young doctors coming out will have some awareness of the illness. But again, because there are so many thousands of illnesses, a GP doesn't know a lot about everything. They know a lot about, you know, treating the common cold and the everyday stuff, and the illnesses like sort of thyroid disorders and diabetes and blood pressure and what have you. But this is a very specific kind of illness, and probably, if anything, falls into the realm of the neurologist. It's become identified by the World Health Organization and the International Classification of Diseases as a neurological disease. It's got a definite classification. So it is classified as neurological disease, but your doctor is the person to see first and foremost to try and get elimination of other illnesses that have similar symptoms. So a lot of the blood tests and the approach the doctor can take is certainly going to be a good start, if you like. And there are definite criteria that the doctor can look up to try and make a diagnosis. But I think if you or a doctor suspects that this might be the illness, then your doctor can refer you on to a neurologist or a rheumatologist. They deal a lot with the people who have a lot of musculoskeletal problems with this, like fibromyalgia, which is like a sort of rheumatological pain. So rheumatologists and neurologists are the people who would deal most thoroughly with this illness, and sometimes of course it may be a hormonal issue that's aggravated and can be helped. So things like going on to see even a gynecologist for a woman or a hormonal specialist. So, you know, there are kind of various routes towards a diagnosis, but again, I won't acknowledge that it's easy. It's not easy sometimes.
I just wanted to comment on that. The reason I asked that question is because I was hitting my head against a brick wall with my GP, so I've changed my GP.
Yeah.
And it's more about understanding what the pathway is to make sure I can get that help. And if you go through to the rheumatologist,
Yeah.
what are they looking for? What markers? Is there something?
Well, there aren't any real markers as yet for this illness, and that's one of the problems. And I mean, let's face it, in reality, there are many, many illnesses that there are no markers for. You know, this isn't so very abnormal. There are lots of illnesses that there are good markers for, and a blood test will, yeah, there's your diagnosis. This illness there aren't, and it makes it very, very hard for, well, particularly for the patient, but also for the doctor, because you haven't got a specific marker that you can say, yes, this person's got chronic fatigue syndrome, therefore we take this path towards dealing with it and treating it.
My other question was, is there any correlation between Graves' disease and chronic fatigue?
Well, Graves' disease is a thyroid disorder, and they have very similar symptoms often, but they are quite different. But you can have both things, of course. I mean, I think we often forget the fact as individuals that you can have more than one thing wrong with you, which is rather depressing, but there we are. It can be that, you know, you can have, someone can have 4 or 5 things wrong with them, and if you've got more than one thing wrong with you, it's always going to aggravate each other, or a tendency to aggravate each other, really. So, you know, if you've got a heart defect and thyroid disorder and chronic fatigue syndrome, you know, you're kind of in a bit of a mess, and these things always aggravate each other. But that's part of being a live human, really. We can get sort of more than one thing wrong with us. Yeah.
I wish you to explain the mechanisms that are involved in POTS.
Sorry, I missed the...
Can you explain the mechanism?
Oh, the mechanism.
POTS and how you deal with that?
Right, well, POTS is something that, it's that sort of tendency to feel very faint if you're standing up for any length of time, or if you get very hot, or your heart beats very rapidly as part of that trying to compensate. It's due to, if you're standing up, your blood tends to fall into your feet a bit because you've got very low blood pressure, and then, you know, you begin to feel very faint and often nauseated and very unwell. And it's a recognized medical condition. It's not exactly a disease in itself. It's a set of symptoms, if you like. And so depending on the underlying cause, that will be treated accordingly. And it's diagnosed by, I mean, they have a thing called a tilt table, and they can, for Greenland Hospital, for example, has one. They put you on the table and then they tilt it up like that, so your head's up here and your feet are down there. So it's kind of putting your system into a POTS type of issue, and so they can make a diagnosis because your blood pressure goes extremely low and your brain is sort of drained of oxygen. So that's how they make a diagnosis, and it occurs sometimes on its own. It's a condition that some people have. It's not a disease as such. Sometimes it occurs in association with another illness, such as chronic fatigue syndrome. And the usual treatment will be certainly learning how to cope with it. In other words, not standing upright for a long time in a hot situation, whereby you get very sweaty and all the blood's falling to your feet and you feel very faint and you have a very nasty, panicky sort of feeling. So it's a question of saying, let's recognize this is POTS, how do we deal with it? And certainly plentiful fluids which have a high level of salt can be very, very beneficial. They improve your blood pressure and improve your circulation. And there are various drugs that can be used that will help overcome it too. Okay, so I don't know if that answers your question, but it's a difficult one in that it's not exactly a disease, it's a condition that you happen to have, and it's a question of learning to cope with it and live with it as much as anything.
So can that cause you to be more accident prone?
Possibly, yes, possibly more accident prone, because your brain is the oxygen to your brain is very sluggish, so you may not be thinking as sparkily and quickly as you ought to be. Yeah.
You mentioned, just going back to your slide on sleep, mentioning that Zopiclone doesn't necessarily take you into a deep sleep, but you recommend Nortrip or Amitrip. If someone's got long QT syndrome, they can't take those. Do you have any other suggestions, or we're getting outside of your
Well, it gets outside my sphere a little bit. I would recommend anyone who's got, complex issues should see a sleep physician, actually. And there are some good sleep physicians around, and that can be through the public hospital system too. Yeah.
Yes, Dr. Vallings. I actually suffer from that condition as well. That chap was saying about the long QT.
Oh, yeah.
And I thought it was my heart about 15 years ago, and they took me in and done all the tests and said,
Yeah.
there's nothing wrong with you. I just felt a pain there, so I have heart problems. Anyway, what happened was, he says, you're fine, we'll put you home in the morning. And all of a sudden it started going like that, and it miss a beat, miss a beat. And they kept me, and they just says it's just what it is.
It's a part of you, yes, yeah.
And I asked my doctor, and she says it was quite common, but I don't know, because I know another lady's got this condition and she's suffering from the same.
Yeah, I mean, I think, a lot of us have various underlying abnormalities which are probably there. And I mean, many, many people have these things wrong with them and don't even know they've got them, But that's part of the way our physiology works, really. None of us is perfect. I'm sure all of us here have got something wrong with us. We probably half the time don't know it.
So I've been I've been diagnosed with CFS.
Yeah.
And initially, I thought that once I'd rested and taken some time off work and things like that, I could continue with small amounts of exercise, like stretching and a little bit of walking, and build resilience up.
Yeah.
Can you do that? Or
Well, I think you can do it. Up to a point, but you've got to be very, very cautious. This is the issue. You see, there's a great tendency, we feel a bit better, we push ourselves that little bit harder, because that's almost, we're brainwashed into thinking that's what we've got to do. You know, there are all these gyms out there and people pounding the pavements and on bikes and things, and you kind of think, oh, I've got to get up with the play and do all this. But this is one illness particularly where if you push the exercise over that little bit that you can tolerate comfortably, you can run the risk of worsening of symptoms. So I think you've got to monitor yourself really, really carefully and only build up very, very gradually, and realise there may be a limit to where you can get to. I mean, we'd all like to be able to go and run a marathon, wouldn't we? But most of us can't. No, but the reality is that I think most people have ambitions to do more than they should, be it work or exercise or anything else, you know. The reality is we don't push ourselves more than our bodies can tolerate, and it's been shown in this illness you can really create a relapse if you push yourself too hard. And the relapse can be very severe.
One more question. Dr. Vallings will be staying around for a few minutes, but you know, so please feel free to stay around. If you'd like a copy of this, please fill in the form there. We'll make sure that you do get a copy.
Yeah, I can make sure you get a copy of
Yes,
that.
yes.
Yeah.
My last question is, because I'm new on the scene, so who's doing the work that you used to do? Because I was given names in Cambridge, but I'm wondering if there's someone in Auckland.
Yeah, there's, I mean, I retired from my medical practice about 18 months ago, and I've continued to train doctors around the place, actually. I still talk to medical groups quite frequently. There's no one specifically specialising in this illness in Auckland, I don't think, but there are a number of doctors who are quite interested, and I think more will get more interested because the research is becoming more prominent and understood. One of the problems with doctors not being particularly clued up with the illness or interested in it is because the research hasn't been showing what we could and should do for our patients. It's all been a bit hit and miss, you know, and that makes it very, very hard. But there are doctors around New Zealand who are getting interested. I think Warren Tate's work down in Dunedin, he's talking to the fairly senior medical students now every year and giving them a lot of information, so these young doctors coming out of Otago will be very clued up, which is good.
I just asked that question because I've gone 3 years having my head on the wall with my current doctor, and she reluctantly gave me that diagnosis in the end. I didn't really want that diagnosis.
No.
And the care wasn't there.
No. Well, I think a lot of practice nurses and physios are now getting some education about the illness too, and I think it is an illness that can be managed as a sort of team approach, and so physios and practice nurses are very much going to be in the firing line to help people with this illness. There's more and more education for them being done now.
Do you see a magic bullet for this in the near future, or no, really?
I don't think I would commit myself to saying there will be a magic bullet. I think the incredible advances in the research in the last couple of years have been really exciting and encouraging, and I think there won't be exactly a magic bullet, but a much more understood approach to management and helping people with the illness.
On the internet the other day, and the AUT is doing a study on long COVID.
Yeah, there's a lot of work now, and I think that's the one good thing that COVID has done for people with this illness. It's created an enormous interest and a huge body of research out there, and huge amounts of money being poured into research for the long COVID, which is the same thing. You know, I think we can't deny there's any difference, really.
It would help us though, wouldn't it? Because it's the same thing, really.
It depends.
But they've opened up a register, and you can go online and register with them. They reckon just about 200,000 people in New Zealand may have it.
Real, yes, I know. It's kind of.
It also depends because I was
Some people have the same symptoms.
I was referred to the long COVID clinic to see whether they could help me, and my symptoms they weren't interested in.
Don't what? Sorry.
They weren't interested in my symptoms.
Really?
Because it wasn't respiratory.
Okay. Yeah. No, I think again that will change over time, hopefully. So COVID might have done some good for people with chronic fatigue syndrome, if you can call it good. Okay, well we better stop, hadn't
Sorry,
we?
you've got one last question. This is the last question.
It wasn't a question, I just thank you for all the years of hard work
Oh well,
you've done and sharing and
it's quite fascinating for me actually. I've never been bored by it, so you know.
And we as a Trust want to thank you, Dr. Vallings, for giving up your precious time, and also for you people for attending today.
Yes,
We
yeah.
know it takes a lot, sometimes to just get out of the house and to attend here. And thank you for understanding our room and a change of venue.
Well, it's quite good actually, isn't it?
It is.
Yeah,
It's more, more family-like.
Yeah.
But we do want to thank you for the great work that you do.
Oh well.
And we, of course, as a trust, will use you over and over again as Wendy. And for me, working for the trust,
Yeah.
I've appreciated hearing what you have to say.
Well, I think I can only thank the Trust for all they're doing. I mean, they really are working
we're
hard.
Trying, so if you'd like to find out more about us, we've got some membership forms there. It's free. We will not bombard people. We do have meals that we can get out, which is soups from Patango that we send to people, because sometimes it's just hard to actually cook. We have a mentors group as well, so it's people who are like-minded that can get together and just talk. It's all online. We have a craft group. We are working down the line of getting a respite place as well, but it's just small steps. So thank you, Dr. Vallings, for your time. We'd just like to thank you.